So there are two main types of anesthesia. First is the general anesthetics, which makes the whole body lose feeling, movement, and consciousness. Drugs that are used to induce this type of anesthesia are called the general anesthetics. The second type is the local anesthetics, which numb only the specific targeted area of the body. And drugs that can be used to induce local anesthesia are called the local anesthetics. Now, anesthesia performed in general anesthetic. These four stages essentially remain the same over time. However, updated delivery method and modern anesthetics have improved speed of onset of safety and recovery. So the first stage, known as the induction. Induction is a period which from state of consciousness to state of unconsciousness. Next, we have the second stage. Second stage, known as the excitement. Second stage known as the excitement. So, at this stage, depression of inhibitory neurons leads increase excitement, and involuntary muscle movement, increase heart rate, blood pressure, and respiration. We progress to the next stage known as to the third stage known as known as the surgical anesthesia. Surgical anesthesia. At this stage, there is a gradual loss of muscle tone and reflexes, and patient are fully unconscious and unresponsive to surgery and has irregular breathing. So this stage is ideal for surgery, and careful monitoring is necessary to prevent further progression to stage 4, also known as the medullary paralysis or overdose. So at this stage, respiratory and cardiovascular failure occurs, which lead to death if the patient cannot be revived quickly. So now let's move on to discussing how general anesthetic works. So the mechanism of action of general anesthetics is not entirely clear, although early theories focus on a single common path of action for all anesthetics. Over time, it is increasingly apparent that multiple sites and different mechanisms are most likely responsible for the effects of general anesthetics. So, at macroscopic level, the action of general anesthetics on thalamus and reticular activating system leads to reversible loss of conscious. So the action on hippocampus, amygdala, and prefrontal cortex causes amnesia. And then lastly, for the spinal cord is irreversible for immobility and analgesia. Now at molecular level, things are getting a little bit more complicated. So to make things simple, we can divide the general anesthetics into three groups. Yeah. So based on their abilities to produce unconscious immobility and analgesia. So for the first group, it consists of intravenous agents like etomidate, propofol, and barbiturates. So these drugs are much more potent at producing consciousness rather than immobility or analgesia. And they are commonly used in induction phase. So their effects appears to be more mediated by subset of GABA aminobutyric acid type A receptor, in short GABA A. So GABA A are located in postsynaptically and extrasynaptically on the majority of neurons in the central nervous system. So they are composed of pentometric. They are composed of pentometric arrangement of subunits around the central ion channel pore. So when endogenous GABA binds to the receptor, it causes a conformational changes in which opens the central pores, allowing the chloride to pass electrochemical gradient. So this in turn leads to stabilization or hyperpolarization at resting potential, making it more difficult for excitatory neurotransmitter to depolarize the neuron and promote an action potential. So the etomidate, propofol, and barbiturates bind to specific sites on the GABA A receptor. So they prolong the opening of channel, suppress neural excitatory, and thus promote unconsciousness. Now, when it comes to the side effect, etomidate can cause adrenal suppression, and transient skeletal muscle movements, including myoclonus. Propofol is known to cause respiratory depression, respiratory depression, and hypotension. Lastly, the barbiturates. Barbiturates can cause apnea, cough, apnea, cough, bronchospasm, and apnea, cough, bronchospasm. And just like propofol, barbiturate also causes respiratory depression. So group 2 general anesthetics also affects the members of the 2,4 domain potassium channel family, which regulate the resting membrane potential of neurons. Specifically, they promote the opening of these channels, leading to increased potassium efflux, producing a reduction in urinary excitability that contributes to their. Now, when it comes to side effects of ketamine, ketamine causes hypertension, bradycardia, and hypersalivation. As well as emergence in phenomena ranging from vivid dreams to hallucination, vivid dreams to hallucination, and delirium. That may continues for 24 hours after treatment. That may continues for 24 hours after treatment. Next, we have nitrous oxide, and cyclopropane. That are known to cause dizziness, nausea, and vomiting. Lastly is the xenon. Xenon, which has many characteristics of ideal anesthetics. Lastly, we have xenon. Xenon, which has many characteristics of ideal anesthetics and has virtually no significant side effects. So now let's move on to the group 3 of general anesthetics, which consist of halogenated volatile anesthetics such as the halothane, enflurane, isoflurane, sevoflurane, and desflurane. So in contrast to group 1 and group 2 drugs, group 2 drugs have more diverse mechanism of action and more potent at producing immobility. Studies suggest that volatile anesthetics produce unconsciousness via different GABA A receptors, solubility subunits than those targeted by the group 1 drug. and also may 2,4 domain potassium chloride channels that are activated by group 3 anesthetics appears to highly affect rather than anesthesia. So just like the group 2 drugs, volatile anesthetics also inhibits the NMDA receptors, a wide variety serotonin type 3 receptor, sodium channels, mitochondrial ATP sensitive potassium channels, a hyperpolarization activated cyclic nucleotide gated channel. So now when it comes to the side effects of all agents in the group, produce a dose-dependent reduction in blood pressure and cardiac output. Additionally, halothane in particular may produce or may cause cardiac rhythm and hepatotoxicity, while sevoflurane may cause renal toxicity. So before we move on, there is one more agent that's worth mentioning here, which does not belong to any of the groups that we discussed so far. That is dexmedetomidine. So unlike other commonly used general anesthetics, dexmedetomidine has a unique ability to produce sensation and analgesia without the risk of respiratory depression. So these effects result from its binding to presynaptic alpha 2 receptor adrenergic of the subtype 2A, which is located in the brain and spinal cord. So the action on the receptor inhibits the release of norepinephrine, terminating the propagation of pain signals and inducing light sedation when it comes to side effects of dexmedetomidine. So the most common ones are bradycardia, hypotension, and transient um, hypertension due to peripheral alpha 1 receptor agonist activity. Now let's move on to the brief discussion of the pharmacology of local anesthetics. So unlike general anesthetic, local anesthetics produce transient loss of sensory perception, especially of pain in localized area of the body without producing unconsciousness. So how do these drugs work? So due to the distinct chemical properties, local anesthetics are able to pass through the membrane, through the neuronal membrane and bind to the specific receptor at the opening of voltage-gated sodium channel, thus preventing sodium influx and in turn prevent the inhalation and conduction of action potential, which ultimately leads to the loss of sensation in the area supplied by the nerve. So examples of most widely used local anesthesia are the bupivacaine, lidocaine, mepivacaine, procaine, ropivacaine, and tetracaine.